Thanks a lot. I would like to thank Amitabh, Sanjeevan, and the team of Narayana Hridayalaya, Howrah, for giving us this opportunity. So we have here, my team is Dr. Vishnu and Dr. Pramod Sagar and Sister Janaranjani. And at the radiographers, we have Prabhu and Surya. Selvakumar is our intensivist monitoring the patient's anesthesia. The patient is on general anesthesia. I request Anand Kumar, one of my colleagues, to give the brief clinical presentation.
Good afternoon. Our first case for pulmonary valve implantation is an 18-year-old male with complaints of class 2 effort intolerance for past 1 year. He was diagnosed with TOF in early infancy and underwent ICR with VSD patch closure, infundibular resection, and transannular patch reconstruction of REOT in 2005 at 1 year of age. This is his current ECG, which shows sinus rhythm, normal PR interval, and complete RBV, QRAS duration of 160 millisecond. Echo showed intact VSD patch, severe PR, dilated RA-RV with mild RV dysfunction, and adequate LV systolic function. This was a cardiac MRI, which showed a PR fraction, severe PR with a PR fraction of 55%, elevated RV end diastolic volume of 166 ml per meter square, and RV to LV EDV ratio of 3.25, and RVEF of 49%. This was satisfying criteria for pulmonary valve implantation. So we did a cardiac CT for RVOT dimensions. The proximal, it gave a maximum dimension of 30 mm distal, and length was 27 to 29 mm. These were the RVOT angiograms. REO cranial view gave a dimension of proximal 28, mid 28, distal 29 mm, and length of 27 mm. The LAO cranial gave a proximal dimension of 37 and distal of 30 with a length of 22 mm. The lateral view gave 29, 32, and 30 dimensions and a length of 27 mm. We did a balloon sizing, and the maximum waist was 37 in LAO cranial. In lateral, it was 32 to 33, and RAO cranial 31 to 32. And simultaneous LMCA angio showed no LMCA coronary compression. This is a 3D virtual reality reconstruction of the RVOT using a software for trial, which was provided by Dr. Adam from Poland. So this is the first where we are cutting through the RVOT in RAO cranial view, showing almost dilated tubular RVOT and continuing in line with LPA. And this is the cranial projection with the showing the hollow viscus of the heart, and same lateral view. So this is anatomical virtual dissection of showing the RVOT and branch PS alone, where we can do similar cuts, and is showing the LMCA coursing here away from the RVOT. And same cuts in the cranial and in lateral views. So similar projections can be made in angiographic view also, and angulations can be changed similar to our conventional. So these are the RAO, cranial, and LAO projections demonstrating the RVOT that we are going to stent now. And so we can also do a trial. Venous P valve can be positioned in the RVOT and checked for the appropriate size. So we have decided to use 3625 pulmonary valve.
Dr. Bharat, I think you heard the presentation. This boy has got quite a dilated right ventricle, around more than 3 times the left ventricle. He is satisfying the volume criteria, and he's satisfying the regurgitant fraction criteria. He has class 2 effort intolerance, symptomatic as well. So I think we all probably agree that he needs a valve. Is there any question about the indication, Dr. Bharat?
I don't think so. I think everybody agrees. Anybody in the audience has a disagreement? I don't think. I think both by virtue of his symptomatic status as well as his objective criteria.
Yeah, I would like to.
Wait a minute. Varakan has raised his hand. Varakan is joined virtually, I think.
Hi, Varakan. Nice to be doing this case in front of you.
Hi, Shiva, and hi, Bharat, and everyone, Motu. My privilege to be with you. Unfortunately, it has to be virtual today, but yeah. So just a question to you, Shiva. If I understand correctly, the balloon interrogation maximum diameter was just 32 millimeter, right? And in
Actually,
this,
Varakan, in couple of views it was 32, and in one of the view it was 36. I will show
okay.
you some live image now that I have acquired today with the marker pigtail. Maybe I'll show you 3 images and then we will discuss it further. Can you show the so this is in LAO cranial projection that we have got it today. I'll tell about the axis. We have a right femoral venous axis where there is a 24 French long Cook flexor sheath that is going into the region of pulmonary annulus. And through that, there is a marker pigtail. And we have a parallel 6 French pigtail across the left femoral vein. And that is making the angiogram. I'll show you the dimensions. Next picture. This is the right anterior oblique projection, which again shows that the actually in the previous LAO cranial projection, show the previous one. You can see that the proximal RVOT is sort of dilated, whereas the distal RVOT is slightly becoming tapered, indicating that it may be somewhere between a pyramidal outflow tract and the tubular outflow tract. And the second one, RAO, is showing that it's rather tubular. It's not the distal end is not terribly narrowed. Show the lateral. So this is the lateral view, and I will show the measurements now. Show the measurements, the fixed measurements. So this is in RAO projection. We got little smaller diameters. We have 33 millimeter in the mid main pulmonary artery. Annular area is 32 millimeter. So 32 to 33 at the pulmonary annulus and mid main pulmonary artery, and the distal main pulmonary artery is around 29 with a length of around 26. Next picture. This is LAO. LAO is a little larger. You can see that it's around 35 at the level of the annulus, and at the mid main pulmonary artery is 34. Next picture. And this is the lateral. The lateral dimensions are 35 at the level of annulus, 35 to 36 at the mid main pulmonary artery, and towards the pre-bifurcation area it is 31. Is the pictures clear for you on Zoom, Varakan?
I think Varakan is probably he's lost contact.
Okay. Now, Bharat, in the meantime, I wanted to tell the brilliance of one of my colleagues, Pramod Sagar. You saw that virtual reality play that he has been doing. He is interacting closely with Adam Kolesnik from Warsaw, Poland, and both of them, they do a lot of these, the virtual reality gimmicks. And I'm very happy to know that these young brains are far more active and far more dynamic. Their synapses are far superior, and I think the future of pediatric cardiology is far better today.
Shiva, I had one question for you. Now, what numbers would you not go ahead and go ahead with venous P valve? I mean, now this is 32, 33. I agree that the main pulmonary artery is quite acceptable dimensions, but what are the numbers which will make you say that, no, I don't want to do it percutaneously?
Yeah, Bharat, if in all the views, in all sorts of orthogonal views, if the angiographic as well as balloon sizing are more than 34, definitely we will feel very apprehensive. Even if it is 33 plus in all the views, we will be very skeptic. But if it is 34 or 35 in one view, but in another orthogonal view, if you are getting like 29 to 30, we will accept it. We have to understand one thing here. You just see this one particular image that is shown right now. Can you show this picture again? See, this is a picture where my Lunderquist wire is actually stretching the right ventricular outflow tract superiorly. So we can obviously understand that the supra-inferior dimension of the outflow tract here has to be larger, whereas the transverse diameter, like what probably will be getting in an AP view, will be smaller. So even though in this, don't run bus. Okay. So here we can appreciate that the guide wire is actually stretching out the outflow tract, and hence probably 35 may be acceptable, but we have to be we have to understand that 36 is the largest valve in venous, and we don't have anything larger than that. And so we need to be very careful and ensure that the valve doesn't prolapse into the right ventricular outflow tract and into the right ventricular body after we release.
Shiva, Shaq is here in the audience. I would like to take his opinion on this.
Oh, great, Shaq. Nice, nice that you are supervising us.
Good afternoon, Shiva.
Good afternoon.
Very good case, interesting case. I agree with you about the indications as well as the size. I think there are several reassuring things about choosing the size that you did. The only slight difference I would have is I'm slightly concerned about deploying the distal flare in the left pulmonary artery and then pulling it back, because it's a relatively short pulmonary artery. And so it gives you less margin for error. You might be all right. Whereas right pulmonary artery, when you pull the distal flare back, then you've got a bit more control in keeping the distal flare in that tapered part. So that would be the only thing that you'd have to think about. And if you've got a good sheath in the main pulmonary artery and the distal flare comes back too far, then you should be able to retrieve it. So that would be the only thing, but otherwise the choice is fine.
I agree with you, Shaq. I think, see, even though in this particular view that is frozen now, RPA looks slightly larger than the LPA. On CT scan, both of them looked more or less similar, and the left was more in line with the outflow tract. So we discussed in our team and we decided that, okay, let's first start with the left pulmonary artery. I would say that probably in about 90% of our cases we had been doing with the left pulmonary artery, and only in around 10% we had gone for right pulmonary artery. But I agree that the jump will be quite significant if we are coming from the left pulmonary artery and if the distal flare is getting trapped within the left.
And
So, since the valve was out for a long time, out of the eyes, I thought I will take it inside. So now I have this is the 24 French sheath, which is having a little bit of kink. Let me see whether I'm able to manipulate and get it across. Come to AP itself. Okay. The kink is quite tight there. Okay. So now come to RAO, please. RAO cranial. Show that RAO picture once again so that we get a. Yeah, keep running it. Maybe LAO, show LAO because it's not separating it out. Show the LAO picture and get me the LAO 30. Shaq, what do you think will be should be our working initial view for deploying? and that RAO was not separating out the LPA too well. So I'm now choosing the LAO.
I have a very simple brain, I'm afraid, Shiva. So I stick to the lateral
Okay.
initially because you can see the RPA
Start.
going into the picture. When you do if you look at the previous angiogram, you'll see the RPA shadow, and that becomes the landmark for me. So I tend to go lateral.
Can you get 15
Initially.
at 15? 15 at 15. Ready? You keep doing it.
Shaq, you are the only one I have seen deploying in lateral. Most of them will either go for a RAO cranial or will go for a LAO cranial.
The reason is I don't want to confuse myself by too many different projections, and the lateral just for some reason, it's a personal thing. The
Right.
RPA.
No, I take your point. Absolutely. I take your point of that.
So Pramod is now partially trying to open out the distal flare. I will show you the previous picture in the meantime. Show the previous picture and freeze it. Freeze it when the left is seen. Yeah. So we have got our distal markers just distal to the LPA origin. So we are planning to get the valve a little bit opened. Probably I'll wait till the valve is opened up to the distal 1/3 so that the LPA flare really opens out a little better.
Shiva, what is the size of the sheath? 24 or 26?
That's a 24 French sheath. We don't have an access for 26 French sheath in India, Dr. Bharat. The 24 we get from Cook. There is also one from Medtronic Centrant, but we don't have the Gore dry seal registered in our country, and so we don't get an access to this 26 French sheath. So now 50% of the valve has been released. It seems a little deeper for me at this position. So I'm going to make one angiogram. Can you make one angiogram? Okay, so at this point, I'm going to slightly push the wire. Little bit I have come out. Can we have one more picture?
Shiva, Shaq has a comment to make.
At this point, I would also pull the pigtail back because your distal flare is, it's coming back now, very slowly.
Okay, one more angiogram. Dr. Bharat, you had some question to ask.
No, the second question I had in mind was, when do you actually unsheath the valve? At what stage?
See, now itself, my Cook sheath is actually 50% supporting. Now you see that I am going to withdraw the Cook sheath back. So okay, now I am afraid whether, okay, now can you make one more angiogram? Do an angiogram. Okay, so it is it has fallen into the outflow tract. So I am going to resheath the valve. I'll withdraw the pigtail. Okay, now I'm just advancing the whole assembly inside.
Whilst you're doing that, Shiva, this is really not for you, but for the audience here. This was the point I was trying to make about RPA deployment, because from the LPA, there's a very narrow margin of safety on this anatomy, this patient's anatomy, not normally, but this one.
Because of the short MPA.
Yeah, and also the tapering that is slightly more distal.
No, you try.
If the part of the distal flare jumps down, it's really uncontrolled. So that's why for this, I would have gone for the RPA, and then you've got a bit more control in pulling back. Then it's more difficult.
I think I agree with you, Shaq, probably because this was falling back. Maybe what I will do is I will go offline now. I will change the position into the right pulmonary artery and then come back to you. Or you would like to see
I think
our
that
changeover?
would be a bad idea, Shiva. You can take your time and do the RPA, and whatever time you want to come back, we will be there live for you.
The RPA angle will be such that it'll be a little bit more difficult to get the valve round, but you should be able to.
Okay. So now what I will do is I will take out the valve just to check the valve whether it is fine. And then in the meantime, try to relocate the wire into the left, into the right.
So, Amitava, can we go on to the next talk? Till that time, let Shiva go on to the RPA.
So we'll,
If there are any questions or comments, and even if Shiva is working, Shaq is here, so he may be able to take some questions.